Thank you, Dr. Kigamwa, for accepting to be with us today to answer some of the questions that some of our patients who you refer to us often have. In particular, we'll be looking at mood disorders. So we hope that you'll be able to expound on this matter. Karibu.
Thank you, James. It's my pleasure to be able to contribute to this topic.
Thank you. So to just start off, how can you describe mood disorders? What are mood disorders?
Mood disorders, as the name suggests, are disorders that primarily affect the mood. And by definition, mood is the emotional feeling tone of a person. And that emotional feeling tone can become disordered in various ways. According to our catalog of mental illnesses, which is known as the Diagnostic and Statistical Manual, we diagnose these things based on specific criteria. Because if you were to do tests on individuals with mood disorders, you'd probably find some aberrations in certain chemicals or hormones in their brains, but these are not commercially available. And so, because we don't have a huge stethoscope you can place on someone's head and that would allow you to make a diagnosis, we depend a lot on what we call diagnostic criteria. Now, according to those diagnostic criteria, mood disorders are classified into unipolar disorders and bipolar disorders. Unipolar refers to major depression disorder and something called dysthymia, which is really just chronic unhappiness, which does not approximate the criteria for making a diagnosis of depression, but has similar attributes. So those are your unipolar mood disorders, and then you have the bipolar mood disorders, and here we are looking at bipolar 1 mood disorder, which involves a person getting episodes of mania. Mania referring to a person who gets extremely excited, elated, euphoric, or just very irritable, combined with hyperactivity, over-talkativeness, having very many plans and ideas, feeling super creative, may do stuff on impulse like gambling, using substances, even sexual indiscretions, may be grandiose, may become extremely generous, and may even go on spending sprees. That's mania. So when you have a person who has had even one episode of mania, then a diagnosis of bipolar 1 is made. Then we have bipolar 2, which is a milder form. The person does not have features of full-blown features of mania, but has some features of mania combined with an episode of depression. So for a person with bipolar 1, an episode of depression is on the way in 99.9% of the times, and that's why it's referred to as a bipolar disorder. Then we have a thing called a cyclothymia, which is really just rapid changes between mania and depression, and the episodes are very short-lived and they keep recurring at a fairly rapid rate. And so those are the mood disorders as we understand them from our diagnostic catalog.
When you describe some of the mood disorders, and we found that people get stressed, and depression is a common word. You find people talking about I'm very depressed and in every little thing. So what's the main difference between stress and depression?
Oh, thank you, James, for that question. It's a dilemma for a lot of people because we're using those terms loosely. Stress, in lay terms, really just means that a person's psychological coping mechanisms or resources are stretched. Does not really refer to a clinical entity like depression. Depression has very specific diagnostic criteria. Like I pointed out earlier, you cannot take an X-ray of somebody's brain and say they have depression. But if they tell you that certain symptoms are aggregated together, number one, a depressed mood for a period of at least 2 weeks or longer, depressed mood, loss of interest, feeling very bored and disinterested in most things, combined with the biological symptoms of sleep disturbance, appetite disturbance, energy disturbance, and libido, loss of libido, as biological symptoms. And then there are psychological symptoms like losing pleasure, not being able to enjoy things you've enjoyed in the past, feeling hopeless and worthless and helpless and suicidal. And then there are cognitive symptoms like difficulty making decisions, being indecisive, feeling inappropriate guilt, which is more of a psychological symptom, but inappropriate guilt, small things that happened in the past, we now seem to assume a certain level of significance from the individual. And you don't need all those symptoms to make a diagnosis. In fact, the catalog says if a person has had either a depressed mood or loss of interest, then they need 4 of the other symptoms. But if they have both depressed mood and loss of interest, then they just need 3 of the other symptoms. So it's easy to make a diagnosis, and it's clearly a very different phenomena from stress. Yeah.
So what you're saying is everybody goes through stress at one point or the other?
Indeed. Yeah. Indeed, stress is very much a part of our existence. And in fact, we do know that there's some stress can be useful in motivating, in driving, in creating a certain sense of urgency in doing things, and which raises our ability to achieve things that we want to do. Okay. Yeah. So there's useful stress. Yeah.
Now, looking at the admissions that we've had over the period of 10 years, we are noticing that lately we are seeing more of bipolar mood disorder admissions. So we are wondering, is there a specific reason why there is more diagnosis on bipolar than before? Or have you noted yourself?
I mean, I've noted, even in my own practice, that we are encountering a lot of individuals coming up with bipolar disorder. And we think, and this is just a theory, that the age profile of our society is more like 70 to 80% below the age of 20. And these are individuals who are very tech savvy, so they engage with their machines and gadgets, and they research a lot of these things, and they are more aware, and they are not afraid to come forward and say, I think I have a problem that requires treatment. So we are seeing a lot of people now coming up and saying, I think I have a problem. Can you check me? Can you screen me for this? That's one. Number two, that whereas traditionally you would send people to rehab because they were, say, abusing substances, now we try to understand why are they abusing substances. And a lot of times, because of the impulsivity of hypomania or mania, these individuals would present as if they were substance abusers, whereas in fact they have a mood or a bipolar disorder underlying it. And so a person with hypomania, impulsive, a person with depression, maybe self-management for the same reason. So yeah, so truly, there's probably an increase in the number of cases in terms of the diagnosis.
Now that you bring it up, the issue of substance use, again, it's a common question. Which comes first and how do they interact? Is it a mood disorder that will lead to a substance use disorder or vice versa?
Um, the two are, you can't tell because it's like a chicken and egg situation. Where a person with substance abuse may abuse a substance, and the substance leads them to developing a mood disorder. And we are very much aware of things like alcohol causing depression. We are aware of the use of things like cannabis causing a paranoid psychosis. And then on the other hand, a person with depression may find that they're self-managing themselves using a substance like alcohol and so on. So it's not easy. It's not clear cut. We cannot categorically say it's because of a mood disorder that a person has a disorder. But it just emphasizes the point that these individuals require to be screened and properly diagnosed before we can put them in rehab. They do require to be evaluated so that we know what is underlying, what is underpinning the condition.
Okay, thank you. And the issue of environment, Dr. Does one's environment predispose them, if I may say so, to a mental disorder?
Yeah, the role of the environment is also very significant. If just as on top of my mind, on my brain, on my head, I can think of individuals who are brought up in what we call delinquent subcultures. A delinquent subculture would be a culture where the moral values, the individuals live a very exposed life of substances, crime, and domestic violence. These individuals are more likely later life to develop anxiety disorders and mood disorders and so on. When we're thinking about substance abuse, again, if a person is brought up in an environment where the substance is being used liberally, they are more likely to indulge and use the substances later in life. So the environment matters. When we think about the social theories of things like schizophrenia, we are told about double bind communications in those families where an individual may get double messaging or double meanings to very fairly straightforward instructions, and that can also predispose or even cause individuals to develop schizophrenia. So I think the role of the environment is very important. Yes. Okay. Whether you're picking substance, mood, psychosis, all of them.
Which again leads us to our next question. When we talk mood disorders and other mental disorders, then the presumption is that somebody will have to be under medication. And a lot of our patients, either the patients themselves or the families, have difficulties accepting medication. So what's the role of medication in all this? What do people need to understand before they take medication? And the most common question that we find from significant others is, we do not want our person to be on medication because they will get hooked to medication. So cannot be hooked to medication.
Well, you've got to go back to what causes mental illness. The common mental illnesses are really genetic in nature, whether you're thinking bipolar disorder, schizophrenia, anxiety. And when something is genetic, Number one, it doesn't go away. And number two, genes translate into chemical processes and enzymatic processes. And to manage them, you need a chemical, a biological method to manage it. And if you do not apply the biological, shall we call it gene therapy, then the gene will have an opposed action, and sooner or later the symptoms come back. So, so the role of medication cannot be questioned. Number one. Number two, these illnesses do not cause you. These medications do not cause a dependence. It's when you use them, they are treating a symptom. And so when you stop taking the medication, it's not because you're addicted that the symptoms come back, it's because the gene is having an opposed action. But having said that, we have patients who will have been fine all their lives until they're about age 21, 22, 25. And then they get their first episode, and you can ask the question then, what happened to them? Why have they been well all this time and now they're developing the illness? And we say what you inherit in terms of genes is not an illness. You inherit a vulnerability that can lie dormant in you all your life. And so if there are enough factors conspiring, and for most people the stresses start accumulating around the age of, as you start to become a young adult, 19, 20, 21, then those forces then trigger whatever was dormant in the individual. It's quite conceivable if we could eliminate all those stresses. Let's say the person has been triggered into a manifest illness, and then you say, oh, it's because you got married, oh, it's because you went to university, oh, it's because your relationship broke down. What if we said, don't go to university, don't get married, don't get into a relationship, just be a herdsman in the village? That predisposition could go back to being just a predisposition rather than a manifest illness. But of course, in reality, we know that once you start acquiring these adult expectations, people want you to get married, want you to get children, they want you to finish university, they want you to get a mortgage, they want you to get a car, they want you to get a shamba, and so on. So the forces, the stresses will never end. They're always there with you. So yeah, and then also, the vulnerability varies from individuals to individuals. There's individuals who, it doesn't matter what you throw at them,
They're able to cope.
They cope, they manage themselves very well. So yeah, so that's the reality of it, that the medications do not cause a dependence, and that these illnesses in the majority of people are genetic and are not going away until the day we discover how to switch off the errant genes.
All right, Dr. As we come to a conclusion, probably to the layman,
right?
What are the most common symptoms that they can identify in either themselves or a close friend or a family member, and they know that here we have a problem?
Well, it depends on the condition that the person has, but for a lot of the conditions, the first things that go off are really the biologicals, the sleep disturbance, appetite disturbance, then the moods, or just a loss of motivation, a loss of interest. The person just does not seem to be the same anymore. They don't seem driven by the same passion. They no longer have fire in their belly. Or they just unkempt, do not care about how they look, or are very bizarre in their thought patterns, in their engagements with others, or maybe even become antisocial, or become obsessed with some abstract things that do not seem to make sense. So it's really a whole array of symptoms, but usually once family members noticed any one of these symptoms, then the next stop should be at mental health practitioner who can then make sense of these symptoms and provide the necessary intervention.
So you're saying any deviation from normal behavior is cause for alarm?
It should be investigated at least until one has make sense of it. Yeah.
My very last question, Daktari.
Yeah.
Again, back to bipolar.
Right.
We are noticing that we have a lot of relapse cases in patients with bipolar mood disorder.
Yeah.
Relapse in terms of when they are comorbid. So we are treating a dependency to a substance,
Yes.
bipolar mood disorder. I don't know if you've noticed this and what would be your thoughts?
Well, it goes back again to just the basic concept of a bipolar disorder, that because of the impulsivity of mania or hypomania, the person very easily loses the control, and they find themselves back there. And the same with depression, that the person may self-medicate because they're in a depressed state. However, if you do not manage the bipolar itself, then you are guaranteed that your patient will never come out of that substance. Yeah. You must manage the bipolar.
Asante sana daktari.
Karibu sana. Thank you. My pleasure.